Hi there, I'm with my good friend Alex Trompeter, and we are talking about Shatzker IIs today. Alex has brought along a couple of cases, so let's just plough straight into them. First one, so this is a skier, and so it's a medium to high level injury. Alex, talk me through these x-rays.
Yeah, thanks Pete. So it's a closed injury, she's neurologically and vascularly intact. What we've got here is a simple split depression fracture. And we can see that when we look at the x-rays, primarily on the left-hand image here, the AP view.
Yeah, so
that sort of double view of the lateral joint margin. I can't see through the joint nicely. I've got this sort of double shadow. You can see where the joint has crunched down a bit. And I can't see anything on the medial side at all. The medial column looks good. The tibial spines look good. And then when we look at the lateral view, we've got the hemarthrosis we can see, and then on the tibial side we can see that sort of anterior portion of the lateral joint has been pushed down. So when I look at these x-rays, I'm trying to look and anticipate what the CT is going to show me, and that's going to show me probably here some anterolateral depression. I'm also just checking for other little signs, like is the knee subluxed, is there anything else going on here that might just throw a curveball in. But this is
you sometimes see something around the back cortex, don't you?
Exactly, if it's going round, if it's more of a posterocentral or posterolateral injury, then it might curve around the back. But this looks like a pretty straightforward sort of split depression.
What's the personality? I keep talking about personality. What's the personality of the depression, do you think? Is that a nice one to fix or not a nice one to fix?
They're all nice to fix.
No, in terms of like,
so I think
bringing it up.
Yeah, these are the personality of this injury is it inherently wants to fall into valgus. So number one, when I look at these, I'm going, what's the mechanical deformity, and what am I looking for at the end of the operation to avoid? And I don't really worry so much about the perfect joint surface. I worry about knee stability.
Right.
So key number one is for me is this is all about providing a stable joint with alignment.
Yep.
This wants valgus, and therefore I need to stop valgus at the end of the operation.
Deny it valgus, yeah.
Deny it
and
valgus.
You can see that sinking in, can't you?
Yeah,
this is the back of the tibial plateau, of the lateral plateau, just there, and yet the lateral femoral condyle, which I think is this guy here, is already kind of falling into that anterior depression,
which is why you can't see through the joint on the other side, on the AP view.
Exactly, you can't see, because actually this back cortex here is intact, isn't it? He's okay. So it's already falling down.
Exactly. Now the big challenge with these is if the surface is sort of crumbly and comminuted versus if it's like one big nice iceberg.
And that's what I was kind of getting
at. Which is the next thing to then think about. And the question is, if you've got a big iceberg, you kind of, and I call it an iceberg because the joint surface is a little bit above the sea, and then it's got this massive bit below.
Island of bone.
And that's the bit you want to lift up. If it's a crumbly little bit, the danger in these is if you just take the little crumbly bits on their own, they'll just come back down again.
Right.
And what you need to do is make an iceberg and take as much of that metaphyseal bone up with it, and that will then help you.
So is this crumbly, or is this iceberg?
So it's a bit of both. She's good bone in that she's 32, but it is relatively small. But you can see the individual components of double density.
This dude.
So they've got sort of 2 or 3 little icebergs, but I like to take up a bit more bone still with it if I can.
Right.
But the bone quality here will take being osteotomized and being lifted.
So you're thinking an osteotome something like this, are you?
Yeah, so sort of just trying to take as much of it as a oneer as possible and lift it as one.
Right, so rather than going after the individual fragments, you're taking the subchondral bit, the metaphyseal bone, recruiting bone, if you like.
Yeah, exactly.
Nice.
I think if you take the individual fragments here, you'll get it looking nice, and then you'll really struggle to hold on to them.
Tell me about what you get from each slice on your CT. Let's go right to left. So coronal, what do you get from that?
So the coronal here, I'm looking at a couple of things. Condylar widening.
Yeah.
Okay, so that's a really key
that's
key thing.
This guy versus this guy.
And that tells you have to have a split. Even if you can't see a split, you know you have to, because the condyle can't get wider without splitting.
Yeah.
And so when we talk about sort of pure depressions, often you can find there is a cheeky little split in there, bit of condylar widening. It's also going to give me an idea of what I need to chase in terms of buttressing come the end of the operation. In the middle view, I'm looking at the sort of anatomic location front to back of the depression.
Yes.
So is it more posterior, is it more anterior?
Yep.
And then on the axial view, this is the key one, I'm looking for where that split is. And it normally hangs around about Gerdy's tubercle, give or take. And that is going to be your way into the fracture. I tend to work through the fracture, and it's the bit I'm going to use to open up, exactly. And that will tell me where to park my incision directly over.
Great, okay. Okay, incision.
Yeah.
Are you telling me you change your incision depending on where the front door is?
A little bit. Now, for the majority of lateral fractures, that front door sits within about a 10 or 15 degree sort of radius.
Yeah.
There are some slightly funky fracture patterns where it comes more around the side or more around the back, but let's just stick with the Shatzker IIs. The fracture tends to exit on Gerdy's or between Gerdy's and the tibial tuberosity, so around there.
Down around about here.
And that lends itself to an incision that is based over it. Yep. And I tend to keep my incision then in a straight line over that, and it becomes extensile, and it lets me see everything I need to see.
Okay. Hockey stick? Is there a reason to do a hockey stick?
So the hockey stick's well described. I've never been a fan, and my biggest problem with the hockey stick is if you turn the corner at the wrong place, you're in all sorts of trouble. So if you turn it too soon, you can't get round to the anterior corner of the plateau. You can't come across to where that exit might be up at the sort of behind the tuberosity. You can't see those fragments.
Yep.
And if you turn it too late, you can't get down low enough, or you're going to start raising a big flap that you're going to possibly devascularize.
Yeah.
So I try and keep my incisions straight.
Right. So because the posterior leg has got to be absolutely on the money.
And if you're not, you're in all sorts of trouble.
Yeah. Okay. Nice. Okay. Go on then, walk me through this one. So this is yours. This is a slightly crumbly, wanting to recruit bone.
Yeah.
What's your thoughts here?
So what we've done here, it's a little bit ahead of sort of the very first image, but we've basically done our approach, and then we've got a small self-retainer in, and what I've done is I've found the split, and I've sort of winkled my osteotome in there, loosened it up a bit, and then I've basically just gently teased it out. Don't go and sort of lever it in a one-up, because sometimes you'll crack it some more or it'll upset it. But once you've got it a little bit mobile, you can lever it out, and then I'll actually put the self-retainer in the split there.
Right, so you've opened your door outwards.
Exactly, and that then is my working window.
Okay.
Normally then, the next thing you'll see is the joint is down.
You're seeing the surface.
Exactly, and so the temptation, as we talked about immediately, is to try and unpick those individual bits of cartilage and lift them.
Go straight after them.
And what we've done here is sort of come in a bit lower and lifted some of that bone, so they've all come up with a centimetre of metaphyseal bone. If anything, I could have taken way more here.
Right.
If I'd really wanted to.
I mean, you've kind of done it here. What tool did you use for that?
So I get a little Lambert osteotome, one of those little sort of finger surgeon osteotomes or something, but something fairly fine and fairly manageable. Don't go too big, and I kind of work around, and it sometimes takes 2 or 3 sort of laps, if you like, that you're going round under,
making an iceberg.
Making the iceberg, and then gently tease it. If you lever it in one place, you just crush the metaphyseal bone some more. Yeah. And then you end up with just another problem of the same sort, which is you've got nothing. Yeah. So it's all about teasing it gently.
Great. Okay. And
then support it with a wire. And now this is a real key shot. This view here, this lateral X-ray, this is the one you've got to work hard for to check that you've got your reduction, because you can kid yourself on the lateral. And the key thing is to get the femoral condyles overlapped and not rotated relative to each other as well. Yeah. So you don't want to be sort of varus or valgus in relation to the image intensifier, and you don't want to be rotated in relation to the image intensifier. Spend some time getting that, because then you can tell whether your tibial condyle is sort of high enough and reduced enough.
And basically, what you're looking for on that lateral is for the medial and lateral joint lines to be pretty much overlapping. Yeah, I mean, so you can't differentiate one from the other.
Exactly. Now, people talk about, is the medial bumped and the lateral dished or whatever. I think for the purposes of tibial plateau surgery, if your tibial plateau articular surfaces are pretty collinear, you're going to be in a good place. Yeah, I think.
Agreed.
And then the next thing I do actually at this point is I do a little test of valgus on the table now. Okay. Because and you've got to be gentle, but if they're not falling into valgus, I know I've got the joint up to the right space. So it's called height stability. Is that knee now height stable? If it is, we're good.
Some people talk about over-reducing the lateral plateau because it can never be too high. Yeah. So what do you make of that?
I don't love that. That kind of smacks of not having confidence that you've got it in the right place.
Okay,
I don't mean that in a sort of disrespectful way, but
Yeah.
over reducing it with the anticipation that it's probably going to fall back a bit, so your fixation's not going to be solid.
Yes.
I reduce it and I'm going to keep it where it goes, and that to me
Nice.
is, and the guide is the getting rid of any instability from the knee.
Love it. Yeah, okay. Because actually you don't want to be pushing them into varus by
No,
over-reducing
exactly.
the
You can
lateral side.
overcook it. Exactly.
All right, fine. So next slide down, you've got a bunch of K-wires in,
Yeah.
and you've got your plate sitting immediately under them.
Yeah.
I see you've got your ball clamp, your big
Yeah.
ass like King Tong at
Yeah,
the
yeah.
top of the plate. That does tend to buoying off the bottom end of the plate,
It
doesn't
does.
it? How do you manage that?
So here you can see it, and it's starting to pull away a little bit, but I know that the first screw I'm going to be putting in is the buttress screw. So that's going to sit below the apex of that initial
Just
fracture line.
draw that for me.
So if we go back to the original apex, sort of
Sorry.
in that
Okay.
part of town, around here.
Yeah.
We've got the apex at the, he's
Sorry,
done terrible things. Pete, what are you doing? We've got the apex, which is going to be living in that area.
Yes.
And so our first screw
Yeah.
is going to be in this part of town.
Okay.
And that's going to bring the plate in,
Yeah.
and it's going to further compress that. And you can see we've already restored the condylar width here with the clamp, but that's going to even more give me compression across the articular surface,
Yeah,
both
nice.
the clamp and the screw.
Next up.
And so you can see there's that first screw for the buttress. Now
it.
the plate's sat down, and actually at that point, once that screw's tightened, you'll notice your clamp, you could take another notch of tightening again,
Yeah,
because
right,
it's
right.
started to loosen because you've given even more squeeze there. A couple of your wires, if you've got one through the plate, may even bend a little bit.
Yeah, so you're getting some squeezing that
so
way.
you've been squeezing like mad.
Yeah, great. All right.
And there's the finished
there's the
article.
finished
We're just
article,
supporting
nice.
it with some extra screws, really.
Right. Okay. And there you are at the end. And the one thing we didn't see there was an intraoperative lateral, but
Yeah.
the lateral is absolutely key, isn't it, to make sure that you're happy at the end. That you
Exactly.
get the perfect overlapping condyles, and you can see the two joint lines overlapping each other.
And the other thing on the lateral that's really important here is this plate position. It is so common with these anterolateral plates to have them way too anterior. And
When you say two anterior, do you mean that two anterior at the top?
Yeah,
or
so
at the
I'm talking
bottom?
about the top in the metaphyseal part of the plate.
Yep.
People don't fight hard enough to get them round.
Get them round.
And they're a lateral plate. They're not an anterior. You know, they
Yes.
design and they will exert a much better buttress effect. And the other thing you'll know if you've not got the plate in the right place is all of your screws at the top, if they're not in the right place, will try and come out the back of the knee.
Yeah.
And you see that there's suddenly you're like, oh, I can only put a 30 in because it's starting to
Yeah,
leave
yeah,
the back of the
you
knee.
basically put them on the front.
And that means you haven't got it in the right place and you won't be supporting your joint. So you've got to fight to get that plate round into its sort of rightful home.
But you say that, but this was an anterolateral fracture, wasn't
Yeah,
it?
yeah.
So do you sometimes find yourself jiggling, rotating around the
yeah,
proximal tibia to
there's a
fit the
little bit
fracture?
of that, but I think actually most of these, the plate here will accommodate shutting that door because the
Yeah.
condyles come around as one.
Yeah, got it. Nice. Okay, beautiful. We'll come back to that point. So here we've got a slightly higher. There's a road traffic collision.
Yeah.
Young guy who's got a nasty. This is a slightly high energy creature, right?
Yeah, this is a different beast, yeah. There's a few things here that we're seeing that, you know, it's still a split depression. It's still a valgus pattern injury. It's
Right,
still
so
going to want to try and be in valgus. So
There's nothing over here, right?
yeah, exactly. The mechanics of this injury in terms of what's caused it and what we're going to need to do to overcome it are not dissimilar. But the sort of clues in the X-ray here, if you look at the AP view, there's a piece of joint that's kind of several yards down the tibia. This piece here of articular surface. So that's moved south by an inch. The fibular fracture is sort of in there as well, and you know you don't normally see a fibular break in a sort of simple plateau.
Yeah.
So that's telling me there's a bit more energy. And then on the lateral view, we've got this big split all the way down the shaft, and that suddenly is changing the sort of thing like the length of the plate, the sequence of steps we're going to need to do in how we're going to control this injury and what we're going to have to work through.
I perceive that's the thing with the higher up the energy, because there's a danger of like treating tibial plateaus. It's a Shatzker II, and therefore I've got a formula for Shatzker II, and that's what I'm going to do. But at the higher energy level, they have like quirks to them, don't they? Which
absolutely.
are the quirks of higher energy.
Yeah, so higher energy will do fun stuff to your x-rays and fun stuff to your day in the office. You will always get surprises, and the enemy of this is autopilot. Just don't go on autopilot. If you go on autopilot, you'll get your fingers burnt here because you'll put the incision in the wrong place, or you'll come up with that split that you haven't controlled, or you even drive it further apart as you put your screws through the split, or any of those things. So you have to interrogate the imaging and be prepared to adapt and change your sequences or your approaches accordingly.
Okay, fine. So let's canter on to the CTs.
Yeah.
Should we start with coronal, bottom left?
Yeah, so I mean, it's got the depression we expected with the main piece, that very, very big piece on the, there you go,
this
that
guy
one.
here.
So that's a pretty big chunk, and that's the one we could see on the x-ray, but there is a bit more to it, and you can see that depression going up to the tibial spines.
Right in here.
A little bit of comminution out more laterally as well in that, and then a bit more dust as we head backwards. So,
but we do have a bit of a lateral wall to bring in
there
underneath
is, exactly. So there's a little bit of sort of more meat on this bone than with the other one, and then similarly, it is it's central, most of the depression, and it's probably being accommodated by that log splitter effect of the split down the side of the tibia. You can see that
this
there.
dude coming down here.
Exactly. And then there's a little bit of comminution up at the joint level, so it's not going to be an easy read, and you may find you've got a couple of little voids.
Axial. Where's the front door here?
So this is where you've got to really think. You've got 3 doors on this one.
Exactly, you've got 3 doors.
So you've got the most anterior, which is probably not going to be that useful because that's going to be living right under the tuberosity and tendon at some point.
Yeah, because I would argue that's this fragment, isn't it?
Almost.
That's this dude here.
Yeah.
The very front piece.
Right, exactly. Then there's a bit of comminution in there, and I'd be slightly wary of sort of working through the next one.
So that doesn't look appealing because it's all going to fall to pieces. Isn't it?
Exactly. Now that's pretty much where you normally go. The case we just described, and then of course we've got that primary split, which we know we're going to need to clear and work on anyhow for reducing. So it kind of lends itself to being the one we can work through.
Yeah.
But it does mean you're 90 degrees from your normal orientation when you're looking at the joint and doing the elevation and so on. So you've just got to get your head round.
Yeah. You're not coming in here. Yeah. Absolutely. How useful, in split depressions in general, how useful do you find these 3D recons? I mean, they're really nice to look and spin them around and all of that, but how useful are they in this setting?
They're mostly useful for teaching, is the honest answer. I love them for teaching. They're a great visual representation. Sometimes they help. You can sort of really think, oh, my plate's going to sit there. Yeah. But I get 90% of all my information off the axial more than anything. That kind of tells me where I'm going to be doing everything.
Great. Okay. Let's just go through your setup.
Yeah.
Because we didn't mention this last time. So setup for a Shatzker, this is a Shatzker II.
Yeah. So I'm a very simple guy, and for virtually all of my operations, I lie the patient flat on the bed. Yeah. It's a radiolucent bed, just a flat top table. They've got a single sort of maquet block or bump under the leg. I prefer a maquet block, so it just gives a little bit of knee flexion, but it's flat beyond there. So there's one sort of block of black foam.
Right. So this is a block of black foam underneath here. Yeah.
Just flat, nothing fancy about it.
Yep.
No tourniquet, you'll notice. Yeah, don't use a tourniquet for any trauma surgery.
Are you giving it a little bit of head down or not?
Not massively. They all get a dose of tranexamic acid, and you spend 5 minutes at the beginning buzzing the bleeders, and by 10 minutes it's all history. To me, these are high energy trauma, badly injured tissues. I don't want more tissue hypoxia. Patients don't like it. They get pain.
Have you noticed that the patients who you used to put tourniquets on really hated it? Was that a thing?
It's hard to know. It's so hard to know. The anaesthetists will tell you they can see pain responses after an hour and a half. They'll see the tachycardias and bradycardias, and they'll see the physiologic responses as they let them down. And I've just stopped really finding a need for it. And the massive rush of blood you get when you let it down, if you've got to your sort of 1.5, 2 hour time and you haven't finished, and then it starts hosing everywhere, you're like, oh man, it's now made now I'm really tired and sweaty, and now it's bleeding everywhere. So I just can it. You will not regret canning the tourniquet. There is no need for it.
So here we go. This is the incision you were talking about in the previous case. There's Gerdy's. I'll draw you in a little joint line. I'm thinking the joint line is somewhere just about here.
Yeah.
Is that about
Give
right?
or take.
Something
Yeah,
like that,
exactly.
With a bit of posterior slope on it.
And so your joint, your incision straddles the joint line.
Right.
It doesn't start at the joint line, because otherwise you'll never get round enough. You've got to straddle it. This is my working window to see the joint, so I need to see from above and below the joint, essentially.
Right. People are looking at that, thinking, that looks a little bit meepo for my liking. Well, I mean, why not? Why not? I mean, this is the exact incision that I use, ironically, but why not take it down here a bit.
So you can, and there's nothing wrong with that. I don't have a problem with open surgery, MIPO and open. If I'm doing a short plate, then I will probably make an incision that's the length of the short plate.
Yeah.
I can't be bothered to make a tiny stab 5 mils away for one more screw. Just make a bigger hole.
Yeah.
I think there are a couple of issues. So the line you've drawn really brilliantly isn't straight. Well done, Pete.
Yeah.
And it toots off to the medial side, and that's really common.
Yeah.
And the issue is if you're doing a bicondylar, and you end up with a medial incision, you have this issue where the incisions start to converge distally.
Yeah.
And I've seen a fair few cases where you end up with a necrotic bit of skin halfway down the shin.
In here.
Exactly.
Yeah, because
and then you're in all sorts of bother.
Yeah.
And the other thing people say is, oh, but what about a future knee replacement when you're putting the incision there?
Yeah.
And the answer is, well, go back to your logbooks and ask how many knee did you ever see that had a tibial plateau fracture?
Yeah, it's
vanishingly rare. Very few end up with knee replacement. And if they do, you can use that skin incision and still do a knee replacement through it if you just make it bigger, or it's going to be 50 years later, in which case it doesn't matter.
Put your incision wherever the hell you like.
Exactly.
Yeah, absolutely.
Exactly.
Okay, so let's just talk through your approach here. We've got the skin exactly as you've drawn it. Next layer down, you come through fat and you come down to the ITB. That white sheet.
Exactly.
What do you do with that?
So the iliotibial tract is beautiful, and what I do here is you can feel Gerdy's tubercle under it, and it's always there. Even if it's kind of loose, it's still there.
Yeah.
And so broadly speaking, and as we've said, we'll move our incision a little bit depending on where we are, but if we're going for a standard one, I'm going to go sharp onto Gerdy's tubercle and sharp up through the ITB. Really, really careful, proximally, not to open the joint capsule underneath.
Great.
Okay, and that's an absolute killer thing, because if you start opening the joint capsule, you're not going to get your layers and your flaps.
Right. So if this is tibia here, and this is your joint line here, you're hard down onto bone until you get to the top of the tibia.
Exactly.
And then you're just coming through the white layer after that.
And then you'll see the joint capsule bulge underneath
sort
you.
of periarticular fat kind of pushing
fat
up at
and a
you.
bit of joint, and you'll see it and you can feel it and it's bouncy and you can feel the meniscus or the meniscal root, depending if there's a tear or not.
Right.
And then sharp, I will peel the ITB back off Gerdy's going round.
Yeah.
And then I'll release.
Knife, Bristow?
I use a knife. I just do it all with a knife, and then I release the ITB off that sort of capsule and sub ITB tissue further up. Yeah. And you can keep peeling that, in fact, all the way round to the fibula.
Right.
So that's why, if you want to be more extensile, you just make this longer and keep peeling further, and then you can get right round the whole plateau. Going the other way, I peel it, but I'm careful here, because if you go too far, you'll start unpeeling the tuberosity, and you don't want to do that.
Yeah. And I always say to the trainees that when you're peeling it back towards the fibula, get to the fibula. Yeah. There's nothing dangerous there.
No. The nerve's in another plane at that point,
exactly,
and then it's even further behind, because it's behind the fibula there, and then comes around the neck. You're not going to see the nerve.
And the trouble is, if you don't get to the fibula, then your plate will never sit, and it'll be stopped by that capsule.
Exactly. Or
and then it will
worst of all, you put it on top of the ITB, which you've seen people put the plate on, and then you can't. This, if you do it nicely, you will shut the door over the plate at the end and cover your plate with a good quality tissue.
Great. Okay. That's just a meat fest.
You can see a little bit. So we've got a couple of stitches in the meniscal root here. So you can see these sutures here are in the meniscus. So now we're looking, you just got to change yourself. So I'm looking down into the joint from this. So this end here is this is the head. Yeah. This is the toes. Yeah. And we're looking this way into the joint. Yeah. So the menisci are being pulled up by the sutures out the way. Yeah. And we've incised the joint capsule below the meniscus.
Right. So here's our tibial plateau. Yeah. And you've come down. You've come down. You're on. You've peeled off the ITB on both sides, and now you're making a transverse underneath it. Yeah. And are you skinning it down to bone? Are you leaving a little cuff of tissue?
I just take it along. I tried leaving a cuff. It's always slightly underwhelming. So I just take it, and I'll worry about putting it back later. There's normally something either you can do a transosseous stitch or one through the plate,
massive metal plate,
or through your plate. Exactly. Okay. And that will let you look in, and then with a bit of varus and a bit of tugging and a bit of washing, you'll see everything you need. Great. And then you can see here the sort of splits and the joints and that piece of joint that's been rolled out.
Right. So this is this guy here.
That sort of anterolateral piece.
You've flapped out on a
exactly. So slightly different direction to where I'd normally come in.
And then all of the depression and ghastliness is right here in front of you.
Exactly.
Yeah. Okay. Great. Nice. Okay. So here's what you did. You came in. That's the view you had.
So annoyingly we didn't save the picture of us trying to lift the pieces. But what we've done here, again, very similar to the previous, is we've scooped, and you can see where the bone is missing. in the tibia.
Right, there's a void there. Now, isn't
So this is called void management, as I call it. So the void at the time of the injury is up at the joint level.
Yes.
And my job is to move the void south so that it is now in an irrelevant position.
Yeah.
If it lives down there, it's not going to do any harm because I'm going to have screws above it, screws through it, and the void doesn't exist in a useless. It's useless.
Yeah. Okay. Great. So what you effectively did, just to absolutely ham it up, is you put in your Lambotti or your little thing, boom, 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 in a kind of like going circumferentially round.
Yeah, going around, and then also from a sort of anterior view, shelling this way round. I can draw on the screen. But sort of along here, along here, along here, and then you've come round it, under it, and everything, and then lifted it all up with the joint.
Yeah, great. So almost like carving yourself out an iceberg and then pulling it up and up. Lovely. Okay. What have you got next?
And then we pass the wire, and this is just a good tip for people if you find that you've put your wire somewhere and it's doing a great job of holding the joint up, and then you go, oh man, it's right in the way of where I'm going to put my plate. It's just to keep driving the wire through out the other side, and then finish it flush on the lateral cortex, and then it won't be in the way anymore.
Yeah, and then this end is now becomes flush, and then you can put your plate literally directly on top of it. Nice. Okay.
And then, so we've tackled the joint. But what we needed to remember was there's this split down the side here that we need to control. Exactly. Yeah. So we've basically just done a clamp and a couple of perk lag screws here,
just boom,
which has
boom.
taken that and controlled it. And actually, at this point, the fracture's pretty darn stable. Yeah. Because that's going to keep everything up as well, because we've reduced the potential space. The void is down low, the wires are held. I do my test, look at the x-rays I'm fighting for again to look at the joint surface. Yeah. So it's exactly the same as before.
Yeah, you've got a really nice lateral there. Yeah. You've got these condyles and these condyles lined up. And that's, if there's one thing in fixing tibial plateaus is don't judge your reduction until you've got the perfect lateral and perfect AP.
There are so many pictures I see in the sort of people put up in the morning meeting or in cases where they've kind of they've looked at the plateau and they're clearly not looking at the joint alignment and they've not got overlapped condyles, and you're just like, well, you can't make a judgment.
You can't judge it. You can't judge it. Yeah. Okay, so
and then here it's the same story with the plate really. So plate at the top, get it in roughly the right postcode. Get a couple of wires in to hold the plate. You can see exactly as I said, we're going to put the clamp on.
So those wires, that wire, this guy here is actually the
one that we put the other.
He's kind of So that was the one
driven through.
Driven through. This guy is actually all it's doing is holding your plate, holding the height of your plate, isn't it?
Yeah, and when you're using a long plate, the plate loves to kick its distal end up or down and be two anterior, two posterior. So I'll often use 2 or 3 wires once I've got the plate in the right place to stop it rotating.
Okay, yeah. And what's your first move? So you've got your clamp on. At what stage are you going to start putting some screws in the plate?
So clamp on, plate in the right postcode, up and down. So it's in the right sort of area. And then really, again, it's a buttress screw, just like before.
Okay, so and there's it's a metaphyseal one that comes in
roughly where that wire is, give or take.
There. Yeah. Okay.
Exactly.
That looks like a collinear. Is that
it is a collinear clamp, which is just a fancy big clamp, but you can squeeze it even more.
Nice.
So there's the first screw, exactly as we talked about. It's the buttress screw.
This guy.
The big challenge with these pre-contoured plates is they don't always sit perfectly, and that's just life. Yeah. But once you've squeezed them enough, they will actually coapt and deform, and it's still going to be doing a good job.
Exactly. Yeah.
So I don't lose sleep over it.
Don't be freaked out if it's not sitting right.
And for people who are looking really closely, we don't have an absolute anatomic joint reduction. There is still a tiny double shadow, but when you EUA them, they're stable. When you look, their condylar width is restored, and that's all I care about. You can't undo the fact that the joint has been toasted by the injury. So you've got to basically balance the risk and benefit of chasing perfection versus giving them a stable aligned knee. And that's all they need.
Right. And then you secure the...
and all I've done is a long plate here because I knew I had a split to bypass, and I kind of picked an arbitrary long plate out the box. I didn't really measure it and spend hours and hours.
But essentially what you've done is you've done a classic MIPO technique of like here's my articular bit, here's my shaft fixation, and I'm not going to open up the bit in between.
Exactly. Which is exactly what we did. Nice. And there she is. There's the lateral, and again, it looks pretty good. This is why I was talking about getting the plate round to the right place.
Great.
Make sure it's lined. You can see it's trying to leave out the back a bit, even there, but they do.
Yeah. And again, a beautiful lateral, and I'm not really seeing 2 joint lines. I'm seeing just one uniform joint line, which says that we're probably about right.
So it's good.
Great, and there we are. This is like post-op. I'm seeing some bootlaces there. Just tell me what the complication.
Yeah. So compartment syndrome, and it happens. These are high energy injuries, and they occur. They get compartment syndrome pre-op, or they'll get them post-op, and you've got to be really aware of it. This was a bit of a difficult one to judge. She had a lot of just general pain. But if you're ever in doubt, you unzip them.
Yeah.
I didn't do this. I don't use the bootlaces. I just put a simple dressing on.
What about pie crusting? You ever done pie crusting?
Oh, not a fan. Not a fan. So just if you're in doubt, fasciotomy. And the plate's in there already, and that does up the ante for infection if you've fasciotomized or plated. Yeah. But you've got to run with it now. I think taking that all down and converting them to externals a bit harsh.
Yeah.
They've already had their fasciotomy, which is harsh enough.
Great. All right. Shatzker II. Alex, thank you so much.
Oh, pleasure.
Cheers.